So how have we decided to approach genetic testing now that we can do genetic testing so much easier? We can use these large panels that cover many genes. Well, for nephrotic syndrome, our approach has really been very straightforward. We are still not doing genetic testing on everybody as soon as they present with nephrotic syndrome. We're still empirically treating them with corticosteroids, but then as soon as they're steroid resistant, we send them for genetic testing. Fortunately, we get the results back fairly quickly, and we can minimize their exposure to immunosuppressive therapy if they have a genetic explanation. Of course, in patients that we wouldn't usually treat with steroids, so your congenital nephrotics, many of our infantile nephrotics, we go right to genetic testing. We wouldn't treat them with corticosteroids anyway, and we don't have to biopsy them. We get a genetic explanation that's definitive as opposed to a biopsy, which is many times in congenital disease more confusing. For stone patients, anybody with nephrocalcinosis, we go to genetic testing. Anybody who's less than 10 with their first stone, we will do genetic testing. If they're over 10 and they've only had one stone, we haven't been so far doing genetic testing. But if they have a second stone, then we move on to genetic testing. If they have an obvious metabolic abnormality on their 24-hour urine, so dramatic hyperoxaluria, severe hypercalciuria, well, then we would certainly move on to genetic testing. We do defer to testing if there's an alternative etiology. So if it's a neonate who's been on lots of furosemide and has nephrocalcinosis, but we have a good explanation, we don't do genetic testing. Same if they, for example, are on a ketogenic diet and form a stone, or are on another medication that predisposes to stones, we may not rush into genetic testing. Or in patients where it's not really clear if they ever had a stone. Excuse me. You know, you get the patient who had a little bit of pain and some microscopic hematuria, but nobody actually visualized a stone. We'll usually hold off on doing the genetic testing. So for cystic disorders, we're really doing genetic testing on most of the patients, unless there's a pretty established familial diagnosis, for example, autosomal dominant polycystic kidney disease. I just saw a boy the other day who has 6 people in his family with a diagnosis of ADPKD. So I'm not going to do genetic testing on him at this point, although I might do genetic testing on him if I want to screen other relatives as potential donors and use the genetic results to do that. For CAKUT, we're transitioning to more testing. We're certainly not testing everybody with reflux. We're going to do a little bit more in someone with dysplasia. And that's kind of evolving as we're learning more about it. Anybody with CKD of unknown etiology, I'm sure you've all had those patients that, roll into the emergency room and they have a BUN of 300 and small shrunken kidneys, and we have no idea why. We do genetic testing on all of those. And including if we have a good, clinical suspicion of nephronephrosis, because we've been surprised, even though they have smallish kidneys and a history of polyuria and polydipsia, it's not always nephronephrosis. For tubular disorders, we're generally doing genetic testing unless there's really pretty straightforward way of establishing the definitive diagnosis, for example, in cystinosis, where we can very easily do that with a white blood cell cysteine. We're not routinely doing genetic testing yet, although some would argue that that might not be a bad idea. And one thing that we've changed recently is based on the fact that we now know that some people who have, quote, benign familial hematuria or thin-based membrane disease due to a collagen type 4 defect, some of them will end up with significant disease as adults, and therefore they need to be followed. And so we've started, doing genetic testing on all of our patients who have persistent microscopic hematuria without an alternative explanation. We're gonna track that and see what our yield is and see if there's patients that should get it or shouldn't get it. But at this point, we feel it, given the relatively low cost, it's worth doing in that group, because if we identify patients with those mutations, those variants in collagen type 4, we're going to want to follow them long term.